Thank you very much, Mr. Chairperson. Ladies and gentlemen, it is my great pleasure to have an opportunity for this presentation in KHRS 2021. My disclosure information. This is Yonsei University strategy for the repeat AF ablation procedures. Redo ablation rate is about 8.7% in my institute, and the proportion of sinus rhythm, AF, and atrial tachycardia were 25, 42, and 33% respectively. If the initial rhythm is sinus rhythm, we completed Novo ablation gaps and then search and destroy non-PV triggers by ISO provocation. If the initial rhythm is atrial fibrillation, we cardiovert AF first and conduct the same procedures. If the initial rhythm is stable atrial tachycardia, we map atrial tachycardia by high-density map and ablate it with minimal RF touch. Then we complete the de novo lesion set and conduct ISO provocation. So the final common protocol of repeat ablation is ISO provocation and extra PV trigger ablations. How to provoke and eliminate the extra PV trigger in rhythm procedures. After basic ablation protocol, we give isoproterenol 3 to 20 microgram per minute until heart rate is over 120 beat per minute. Isoproterenol dosage is quite variable person to person depending on the beta blocker used. Then we induce atrial fibrillation or tachycardia by ramp pacing up to 120 millisecond pacing cycles. If we fail to induce a sustaining atrial fibrillation 3 times, we finish the procedure. Otherwise, we wait for 3 minutes until the intracellular calcium elevation during AF and isoproterenol. Then we deliver the internal shock 10 to 20 joule to restore the sinus rhythm. Then we wait for 10 minutes of isoproterenol cooling down period. If there is no trigger, we finish the case, but if there is a consistent APC and finally immediate recurrence of atrial fibrillation trigger, we try to map and eliminate those triggers as much as possible. Because we already isolated the pulmonary veins, this IRAF must be an extra PV triggers. Repetitive shock and extra PV mapping is quite painful and stressful procedure, but it shows consistent pattern of a frequent APC is like this. You can map carefully and ablate them all. You can apply 3D quick mapping to localize extra PV triggers nowadays. Then you can have a question. Is this complicated mapping procedure for extra PV foci really valuable during repeat ablation procedures? The answer is yes. Kim In-soo reported the isoproterenol provocation and trigger ablation shows a better rhythm outcome than just a finished case without isoproterenol provocation. However, 12% shows extra PV trigger after isoproterenol provocation, and those with extra PV triggers shows a worse rhythm outcome than those without triggers. Lee Kwang-no published excellent randomized clinical trials which prove the valuable isoproterenol provocation and extra PV trigger ablation. Next target arrhythmia during repeat procedure might be the reentrant type of atrial tachycardia. However, I would like to skip this part because most of post-AF ablation AT are manageable by high-density MAP and high-power ablations. However, I would like to briefly mention about the one remaining challenging atrial tachycardia and this high septal focus. This tachycardia seems like a high septal focus, but was entrained at both sides of left atrium and right side atrium high septal area. So we assume the mechanism of this tachycardia as micro-reentry involving Bachmann's bundle and both sides of septum. But it is not easy to eliminate this kind of tachycardia because Bachmann's bundle locates on the epicardial side and also includes the sinus nodal coronary artery. Also, the width of Bachmann's bundle is quite variable and different person to person. Now, I would like to review our recent publications and manuscript under review regarding the repeat ablation procedures. Most of EP physicians believe that the mechanism of post-AF ablation atrial tachycardia is related to ablation gaps. That is partially true, but we need to consider another factors. Yang Pil-sung compared the Redo case of a patient who recurred as atrial tachycardia and those recurred as atrial fibrillation after excluding antiarrhythmic drug effects. In this study, the patient with less remodeled LA commonly recurs as atrial tachycardia, but the patient with remodeled atrium commonly recurs as atrial fibrillation. Therefore, the Redo ablation outcome was significantly worse in patients who recurred as AF after de novo procedures. Does the number of reconnected PV potential affect the outcome of second procedure? The answer is yes. Kim Tae-won compared the number of PV reconnections and the Redo outcome in this study. In this study, 37% patients remained PV isolation, so no PV reconnection at all at the repeat procedure in spite of a recurrence. The outcome of second procedure was significantly worse in patients without PV reconnection than those with PV reconnection. Consistently, the patient with higher number of PV reconnection shows a better rhythm outcome after second procedure. This outcome reflects the contribution of extra PV triggers with remodeled and the recurred patient without PV reconnection. Park Jae-wook proved the reduced number of PV reconnection as the later timing of recurrence after de novo procedure, recurrence within a year, between 1 and 3 years, and after 3 years. As recurrent timing was later, the proportion of extra PV triggers were lower after de novo ablation procedure. However, in contrast, when 9% of those recurred patients underwent Redo mapping, the rate of extra PV trigger was significantly higher in patients later recurring time after 3 years. These findings suggest AF progression and extra PV triggers contribute to very delayed recurrence after 3 years of de novo procedure. This is not published yet, this study, and Hwang Tae-yeon systematically reviewed extra PV triggers at de novo and Redo procedures in over 2,000 patients with ISO Provocation with consistent protocol. And we found extra PV triggers in 12% of de novo and 29% of Redo procedures. The most common site of extra PV triggers were on the septum, coronary sinus, and the SBCs. LA posterior wall appendage foci still exist, but not in the high ranking. And I would like to emphasize that the 30% of extra PV foci mapped at de novo Redo procedure matched with previous empirical ablation sites. As you expected, the rhythm outcome was worse in patients with extra PV triggers in both Novo and after Redo repeat ablations, and it was even worse in patients with multiple extra PV triggers than those with single extra PV trigger. Park Jae-wook previously proved elevation of left atrial pressure and stiffness at Redo procedures than in de novo procedure. Although symptom score did not change in this study, the increase of LA stiffness was more significant in patients who underwent extra PV LA ablation than those with PV isolation alone. However, this study population was limited to the patient who underwent repeat procedures to measure the LA pressure. So in this time, the EJF estimate the instance of stiff LA physiology by analyzing 1-year follow-up echo after catheter ablation. And this study is also under review. He defined the stiff LA physiology as predetermined echo parameters, and the instance of stiff LA physiology was 3.7%, pretty low. And what is the risk factor for stiff LA physiology? Diabetes, underlying diastolic dysfunction, low LA voltage, and empirical extra PV LA ablation were independently associated with development of stiff LA physiology. Moreover, failed rhythm outcome within a year was strong predictor for stiff LA physiology, and those patients with stiff LA physiology also shows a high recurrence rate, vice versa. Lastly, I would like to introduce several studies regarding sex differences. UITA previously reported that the women younger than 60 years old shows a worse rhythm outcome after de novo catheter ablation, and the mechanism is related to higher parasympathetic nerve activity among young ladies with AF by analyzing heart rate variability. After AF recurrence, which patient respond to antiarrhythmic drug better? Park Yun-jung systematically reviewed the antiarrhythmic drug responsiveness in patients who recurred after catheter ablation. This study is also under review. In contrast, women shows the worst rhythm outcome after AF ablation. AAD response was significantly better in women than in men, especially older ladies. In the Cox regression analysis, women, old age, and the absence of heart failure were independently associated with good response to antiarrhythmic drug. So you can appreciate AAD does not work on patients with heart failure in this study. And in this study, we proved the sex difference of rhythm outcome after Redo procedures. Consistent to the de novo procedure, women shows a worse rhythm outcome after repeat procedures. And the Cox regression analysis, worse rhythm outcome of Redo procedure was independently associated with women, non-paroxysmal type AF, and extra PV triggers. So women and extra PV triggers are poor prognostic factor together after catheter ablation, but antiarrhythmic drug may play some supplementary roles in this patient group. This study, EJL, evaluated sex difference in atrial wall thickness and risk of complication, and we measured the atrial wall thickness by customized software based on CT imaging, and we found the major complication and cardiac tamponade risk was significantly higher in ladies over 75 years old. And these are left and right side atrial wall thickness. Those wall thickness were significantly thinner in those old ladies. Moreover, Kim Daeun evaluated the malnutrition score, and this study is also under review. CONUT score, includes albumin, cholesterol, and lymphocyte count, reflects the degree of malnutrition. It is quite different to BMI measurement. And among over 3,000 patients who underwent the AF ablation, 0.4% of patients had moderate to severe malnutrition in this population. And we found significantly higher overall and major complication risks in patients with malnutrition. And this relationship was more significant in female patients with malnutrition. Therefore, we have to be very careful during the procedures for the patient with small body size, malnourished old ladies who are we are planning an IRAF titration protocol for this subgroup of patients. Finally, I would like to present data of a RELY trial. RELY trial is a randomized clinical trial comparing PV isolation alone versus additional posterior box isolation. This is electrical isolation during the Redo procedures. Of course, we eliminated the documented extra PV triggers and documented the macro or micro reentrant atrial tachycardias. And this brief outcome shows no additional benefit of a POBI, posterior box isolation, even in repeat ablation procedures. So in conclusion, ladies and gentlemen, extra PV triggers are found in 12% de novo, 29% of repeat procedures by ISO Provocation. The patient with delayed recurrence after 3 years have a low chance of PV potential reconnection, which is associated with extra PV triggers and higher recurrence rate after Redo ablation. Existence of extra PV triggers is associated with women, high heart rate variability, higher recurrence rate after Redo procedure, and the empirical extra PV ablation includes stiff LA physiology, which is associated with higher chance of recurrence. There was no benefit of empirical posterior box isolation during repeat ablation procedures. Thank you very much for your attention.